All right. Hi, everyone. Thanks so much for joining us. Can everybody hear me? Can someone just write in the chat box if you can hear me? Oh, perfect. Thank you. Thank you so much, everyone, for joining us tonight. We're super excited to have Dr. Yamil Sid hosting us tonight as he talks about equine emergencies, so cuts, colics, and care. I've muted you all while we do the presentation. There's a little chat box at the bottom of your screen. If you guys have any questions, please feel free to write in the chat box, and we'll make sure that Dr. Sid will answer all of your questions. We're going to be answering questions at the end of the presentation, just so everybody knows, as well as if you're keeping track of your presentations that you attend for either to be entered for our first aid kit prize or for hours for OAVT students. If you could write at the end of the presentation, I'll write at the end of the presentation in the chat box just an email address that you can email me your attendance, and we'll keep track of that. So I'm going to pass it over to Dr. Sid. Thanks so much, everyone.
Sorry, can you listen to me? I think so. Okay, thank you so much for that introduction. As you can see, I'm Dr. Sid, Yamil Sid. Possibly not everyone knows me yet, but I'm one of the vets in the Campbellville clinic. And tonight we are going to talk about the basics of equine emergency, which means for me, the cuts, colic, and care. Okay. By the way, I don't know, only Karen, if you can confirm me that everyone can see my arrow, because possibly I'm going to be like highlighting some points during the presentation, or if anyone is able to see it, that would be fantastic if you can confirm it. Yes.
Yes, we can. Thank you.
Okay, very good. Okay, so we are going to begin with our presentation. So here we go. So, well, usually the emergencies or the basics of emergency involves different things between, and the difference like when you are an owner compared when you are a vet, okay? In this case, we are focusing on you guys. So what you do need to do when you have an emergency situation. First of all, maybe this is like the three most common sense things, but usually it's not pretty common to have that sense at that time because we are in an emergent situation, but you need to be calm. You need to assess the situation and you shouldn't panic, okay? Sometimes, even though that we can see like this body that is here only having a nap, we are horses people and we tend to get panic. I think this is pretty normal, but before of anything can happen, you should be like super sure before like you are trying to contact your vet. Now, when we realize that this is an emergency situation, then we can move forward and then we need to contact the vet, okay? For that, one of the other things that we always suggest is like to have the vet number available all the time and the after-hour service, so you can contact us at any time. You know, in our cases, usually you call the clinic, there's an extended service and they contact us, and then we can call you back to know what is the situation. But also, one of the biggest recommendations is to have an available transportation service. Why? Because these services, sometimes we need to make arrangements in the middle of the night to move a horse that we need to refer to the hospital. When things get worsened, usually we don't want to arrive to that point, but if it's necessary, then we will need to do it, okay? So another thing that it's pretty important and pretty useful to have for you guys, it's always have in the barn or maybe in your things and your personal things in the barn as well, a first aid kit. I just listed here different items that you can have in your first aid kit. For me, if you wanna say like what is very important, I think that at least a thermometer, flashlight, and something to make a clean wrapping will be fantastic, because as you will see later during the presentation, there are several conditions that can lead us like to, in the meantime that we arrive there, maybe clean a wound. That's why also we need to maybe have antiseptics or something to scrub gently the area before that we arrive. But sometimes some complication, maybe they will require that we need to make a clean wrap in the meantime that we arrive to you guys. Okay, another thing is like to make a basic TPR. The basic TPR in these cases is one of the things that we usually do when we arrive to the emergency. We know that we made a full physical exam and we address a lot of different physiologic parameters. But in this case, the TPR means like temperature, pulse, and rate. So temperature, as we can see it here, I put here some values in adults. You have to check the temperature of your horse with a thermometer. We strongly recommend that this thermometer can be a digital thermometer, or if you have a mercurial thermometer, just please put something in the end so you can have it always with you, because there has been some cases that the thermometer goes inside of the horse, and then this is another emergency because the thermometer can break inside of the horse, can poison the horse with mercurial, and can cause the death. Okay, so check the temperature. In adults, the value is between 37.5 to 38.5 degrees. With the fall, sometimes it's even higher, up to 39.5 degrees. But also, we want to, if you can, because this is not something that we are requiring, but if you can, and if you are able and comfortable to do it, if you can take the heart rate of your horse, that would be fantastic. Usually, as you can see, as you can look at me here at the picture, we check the heart rate on the left side of the horse because it's much easier between the armpit and the rib cage. The normal values, the literature says that they can go between 28 to 40. Sometimes we can have some stressed horses that they can show in 44 beats per minute, or maybe 48. For sure, if we have something that it's above 48 to 56, 60, we know that this can be a sign of pain, okay? The respiratory rates go between 8 to 16 breaths per minute. And also, this is very important. I think that possibly you have seen horses that they are stressed because they have pain, they can have an increased respiratory rate. The skin tugger, as you can see here, is this test. Hopefully, I think that you can see my arrow, but when you pinch the skin, and then you can have a value of the possible dehydration or the hydration state of the horse, okay? The test is very simple. You just need to pinch the skin, and usually we want to go back to the normal position just right away. When this is delayed, then we can infer that this is a possible degree of dehydration, okay? And the gums, the mucous membranes, usually we want to see them like in this picture here, pink and moist. You can see there also, I can see like the brightness of the saliva layer in the gums. This is very important because sometimes when you say, like, you know, the gums, they are like maybe tacky or maybe dry. That's another thing that it's valuable for me before that I start to head up to the barn with you guys. Okay, and now we are going to start with the first topic of our 3 topics that we are going to talk tonight. This is the colic presentation, because I think that this is the most common type of emergency that we can have on a regular on-call night. And usually we can say that this is the acute pain onset related to the abdominal cavity. Also, it's very important to remind that not all the times this pain will be related to the abdominal cavity. We can have the same signs or maybe the same presentation, but maybe other organs can be affected. Which ones? The lungs, that can be possible. The pleural pneumonia, sometimes the horses act like they are colicky, but they are not colicky. Or maybe some issue going on inside of the kidneys or the bladder, because also this lives beside of the gastrointestinal system with the abdominal cavity. But it's very important that that we know that like whenever you see colic signs, please call us. Usually I write down here like he or she is not quite normal, because that can be also like a very subtle sign, like you will see in the next slide, that sometimes it's like maybe he didn't finish his meal from tonight, or the dinner, or the breakfast, and we can start from there. Okay, which information is pretty useful for us, like your vet? And the time of onset from the symptoms, like how long ago did your horse start to showing clinical symptoms, to looking at their flanks, to don't be himself or herself. This is very important for us. The behavioral changes, because some horses, they start to be like going apart from the rest of the herd in the paddock, and also that can be a possible behavioral change that can be important for us, okay? And maybe you can even notice it during the day at the barn. If it's possible, as we mentioned it, take the TPR. Another thing that is pretty important for us is the manure that over the last 24 hours. This means about like the quantity, how many piles that we have had from your horse, and also the consistency of this one, because maybe this can be dry, this can be almost covered with yellow mucus. That can be another option. Maybe can be like smaller fecal balls compared with the regular normal size, or maybe can be loosened manure, and we are talking about different conditions that can be going on. Okay, the history of recent vaccination, medication, or procedures. This also is very important, because sometimes during the day in our regular appointments, we can maybe vaccine a horse and have a colicky or secondary reaction to the vaccines. Not all the horses at colicky. Maybe they can show you a fever spike, they don't feel comfortable, but also this is the primary cause, and maybe an underlying condition is like to start showing symptoms of colic. Medications, we have a lot of horses that sometimes we use medications that can have side effects in certain organs. An example of those ones can be maybe the osphos. Osphos is a really good medication, like to certain cases of lamenesses, but we know that before to apply it, we don't want to use anti-inflammatories, and also we want to, the kidneys of the horse are very healthy to avoid this kind of presentation, because also we can have like this colicky symptoms going on, okay? And another procedure, sometimes we can have horses that they have been treated during the day to perform their regular dental work, and maybe after the recovering of the anesthesia, they don't feel like pretty well, and they can start to act colicky, okay? And for sure, recent changes in the feed or the routine, maybe changes of barns, maybe changes in the regular grain that you are buying. Maybe the feed is not the best one. Sometimes we can see like this mold hay that sometimes can arrive to the barn. So this is very important, because that also can be a cause from the colic. Okay, clinical signs. So look at this cutie boy, but as you can see, he's stretching out. He's not right now himself. He's looking at his flanks because he's very uncomfortable. And that's why I just listed here like the possible clinical signs that we can have in the colic presentations, okay? Usually the mild signs, they can be off it, being quiet, watching the flank occasionally, but also sometimes we know that the horses can be twitching the lip or trying to kick their belly. The moderate signs, they are like all the above, plus pawing, rolling, getting up and down a lot, standing in a stretch position, and sweating. In this case, possibly this horse, you can see like at the beginning of the video, hey, maybe this colic presentation is very mild, but you can see that he's flaring his nostrils because he's very uncomfortable. Also, he's dropping his penis. In this case, this is maybe a gelding or a sire, but you can see that this is another sign of pain, or maybe also like the trying to urinate, taking that position can be another sign. And the severe clinical signs can be all the above, plus trying to go down, even when we are walking them, and sometimes they don't want to get up again. So in those cases, please, what do we need to do? first of all, call the vet. We need to address the situation. We want to know what's going on, the time of onset, all the things that we discussed before. We want to remove any source of feed, because sometimes the horses, because they don't know what's going on, they can feel for a while maybe better and they can start to eat again. And sometimes that can be possible, that can worsen the management during the appointment in the barn. Okay. While the horse, if he or she is persistently trying to lay down and rolling, this is very important, because sometimes horses, when they have a lot of pain or moderately pain, they are trying to do that. And we know that whenever they roll, something can get twisted inside of the abdominal cavity, and we don't want that. Okay. Painkillers, I will say Banamine. Banamine, yes, it's possible. What to do for thinking about in painkillers? Always please call the vet. Now, I know that sometimes, because I know a lot of my clients, a lot of you see the horse that maybe is uncomfortable and you gave right away 10 cc's of Banamine. I don't think that's bad, but if you have a mini, or maybe if you have a pony, possibly we don't need the 10 mLs of Banamine. Maybe we need even less. So that's why we need to address the situation as well. And we can advise you with the quantity of this Banamine. Another thing that I want to touch tonight, the routes for administer the Banamine, very important, oral or IV. That's it. Never intramuscular. The intramuscular route for administer Banamine can be dangerous. Tonight, I didn't put any kind of pictures about muscle damage, but there has been reported several reactions or secondary reactions associated with some like septic shot of Banamine intramuscular. This is caused by some anaerobic bacteria, and sometimes the muscle damage can be like very, very widespread all over the surrounding area of the intramuscular shot of Banamine. So if you want to read more about it, please, it's like myonecrosis clostridiasis. You can look for some pictures in the web. They are very, very tough to see it. If you are sensitive, please don't look at them. But I think that this is a really good advice, because there's a lot of people that they believe that it's safe, but sometimes cannot be safe and can be like more expensive compared with beneficial, okay? How much? Again, please call the vet and we will give you our best advice. Now, this is a diagram about like the way that we usually assess a colicky patient when we are at the barn. I want just to put it here because sometimes there's this decision about like whether do we need to treat the horse at the barn or where do we need to go and refer the patient, okay? So initially we have a colicky patient and we are going to make an assessment, okay? Which means a rectal palpation. Usually when we want to confirm and we are suspicious about something abnormal going on in our palpation, we can pop up the ultrasound and make a flash assessment of the abdominal cavity. Or also, this includes our analgesia response. Sometimes, even in the meantime that we are arriving to the barn, you already gave them 10 cc's of Banamine, we arrive, they seem okay, but we want to cover all our bases. And for that, we usually start with the rectal palpation. I didn't put here because once when we start our farm management, we tube them and then we can still like keep going on with the treatment and also the diagnostic. The nasogastric tube is very important for the diagnostic and also for the administration of treatments like electrolytes and IV fluids. But for arrive to that point, we need to like address completely all our parameters, okay? So continuing with this like diagram, if I see that everything here is like controllable at the farm, in the farm, we will start with the farm management. Once we start with the farm management, usually we start to giving electrolytes and water within the tube. And also sometimes we need to do some IV fluids depending on the case and the options to be referred. If refer is not an option, because sometimes there are horses that they don't start to, they don't improve at all. Sometimes even we can think about a planned euthanasia in that case, okay? But also I just try to divide this like very straightforward. Sometimes when we arrive there and there's no analgesia response, even when we are sedating the horse, like a horse that we need to resedate maybe within the next 5-10 minutes. When there's no improvement or of the clinical signs or the heart rate, he keeps like going to laying down, trying to roll, and maybe we have a really abnormal rectal palpation or ultrasound or even reflux in the output of the nasogastric tube. Then we need to think about this is a case that will require hospital management. And then, well, the people at the hospital, they will decide where it needs to be addressed medically, surgically, or maybe even also go back to our option that we don't want to arrive, okay? Okay, let me go to the next slide. Now, I'm going to put here like the choke. I think that this is an emergency that maybe is not a cause of colic, but we know that is related to the gastrointestinal system, okay? So the choke, it's an esophageal obstructions. We are not talking about the windpipe, we are talking about the horses that they start to eat. Always this happen during a meal or after a meal, in the morning, in the afternoon, and they start to eat like very fast and maybe they don't chew properly their food. And we can have some food stuck inside of the esophagus, okay? That's when we start to having a choke because the horse is not able like to pass the bolus towards the stomach and start to have like a kind of reflux of this mouth. And usually you will see this on both nostrils, on the output of both nostrils. The clinical signs, that's why they are the most important is like presence of food and saliva on both nostrils, but also we can have increased respiratory rate and effort because they are stressed, they cannot like swallow. They are rapidly trying to swallow as well, and they even can show cough because one of the secondary consequences because of we have a choke presentation can be an aspiration pneumonia. Okay, this is another case that this horse you can see, possibly he's more quiet compared with the other one, but also you can see here like all this content that is coming out from both nostrils. Okay, so what to do? For me, I would like to say that you call the veterinarian if this doesn't get resolved in the first 30 minutes, okay? We have had, and I have had some cases that you decide to wait 1 hour, 2 hours, and then this get worsened, okay? The treatment to deal with this usually is passing a tube with the horse very sedated because we want to put down his head, gently push that food inside of the stomach. But the most time that this start to keep going on, the most time that this bolus will get dehydrated and will be worse or maybe even tough to keep passing that bolus. Also, in those cases, we need to be very gently. We need to take our time because sometimes even we can make a rent inside of the esophagus with the tube, and that's why I don't want that. And also, I put this picture here. This is a case that I have in Mexico, but we need just wait for a long time and start to rehydrate the horse because sometimes they are very dehydrated, as I mentioned it before. And then also we need like an extra shot of IV fluids to be able like to pass this food towards the stomach, okay? Well, now we are going for the second topic of the night. This is going to be eye injuries. And well, this is always an emergency, okay? Why this is an emergency? Because the eyeball, if you see it by itself, you say like, wow, this is a pretty eye. He has or she has pretty eyes. But the structures, the anatomical structures that involves the eyeball, they are several. We have the eyelids, we have all the bones that they surround the orbit. And as you can see it here, the eyeball by itself have different anatomical structures that can be affected. Okay, which signs do we need to look? Excess of tear production, we can see like cloudiness in the eye, we can see mucus discharge, we can see that the horse is holding the eye closed or is sensitive to light, we can see swelling around the eye or the eyelids, and we can see maybe a laceration beside of it. As you can see, maybe this horse right now is showing like maybe the 80% of all the symptoms that I mentioned to you. He got his eyes closed, swollen. You can see here some mucus discharge, excess of tearing. He's not able to hold the eye open. Also, this one here, you can see this was already stained by me, but you can see here there is a laceration. Usually when we arrive to the barn, we are going to make a full physical assessment. We want to touch all the orbit area to rule out a possible fracture. And also, even though that they cannot have a fracture, we want to be 100% sure that we don't have a corneal ulcer as well. Okay. Also, you can see here in this picture, we are seeing here some cloudiness. This is a really severe corneal ulcer. This wasn't attended. I put this picture here because you can see the comparison. This is our, oh my goodness. Here's our corneal ulcer. This is like severe and deep. You can see like this is part of the cornea, but this is like right now a melting corneal ulcer. You can see this one that right now it's just diagnosed with a fluorescein stain. This looks superficial compared with this one. What can happen with this kind of presentations with a really deep corneal ulcer? Sometimes we even can go there and try to stain the eye. It's not staining, and we can see like the fluorescein going inside of the anterior chamber of the eye. When this happens, we have a rupture of the eyeball and potential iris prolapse. And that is very bad because that means that possibly maybe there's a high percent that we need to take out that eyeball. Okay, comparing the horses between humans, they get inflamed much quicker, and also the cornea, talking about specifically the cornea, tends to degenerate like even like much faster because all the microbiome they have in their eyes and also the rate of inflammation. If we compare a human eye with a horse's eye, usually we can say that the horse's eye get inflamed like maybe 80 times more compared with the human eye. Okay, so what to do? Again, call the veterinarian. Please do not hesitate. Take pictures of the eye or the possible lesion in the meantime that we arrive there. Try to prevent them from rubbing. You can apply maybe a fly mask, or maybe you can put them on the cross ties in the meantime that we arrive there. Please do not apply all ointments. I know that maybe sometimes we have in our locker maybe an ointment from 6 months, 2 weeks ago from a previous injury in an eye. Sometimes this can be contaminated also with bacteria. And then if it was a small ulcer, maybe we can worsen that ulcer because we are putting the box inside of the cornea. Or also sometimes some medications, they can have some local anti-inflammatories like the dexamethasone. But we know that the steroids are not good for the corneal ulcers because they can enhance the developing of this corneal ulcer and they can worsen it, and we can arrive to this deep corneal ulcer like you can see in the picture. Okay, pain management. I think that we can do some pain management there. Usually between Banamine or Bute, Bute is better for the musculoskeletal injuries. But in these cases, when we have some eyes that they can have an injury, we prefer to start with a schedule of Banamine. You can do it like 10 cc's initially in the meantime that we arrive there to keep your horse comfortable. We just talk about if this is a mini, it's a different story about the dose. But the Banamine is the only one that reaches better and crosses the barrier of the eye and get into the eyeball. So that can have like most potent effect of relief compared with the Bute. Okay. And well, this is a clinical case. This involves also the next topic because we can see this is one night on call, and I have this call of this horse that they just brought this filly out from the paddock and she had this laceration, okay? So when we arrived there, we scrubbed the area like with saline and diluted iodine because also eyes, they are like very sensitive. We don't want to irritate them. And then we discovered that we have this very big gash, okay? So I just palpate the orbit of the eye. Anything apparently was broken at that moment. You can see this looks a little bit like rough to see, but I just want to open that eye. And as you can see here in the medial canthus of this eye, there's some discharge staying with fluorescein. At this point, I already stained that eye because I want to rule out, like, even though that we have had this bump on the head and this injury, possibly we can have a potential corneal ulcer. This wasn't the case, so finally we only finished like stitching up the horse, and this horse didn't have any kind of complication and still have his eye on. Okay, so as a reminder, please always call when it's an eye or whenever you think it's an emergency, okay? And finally, our last topic from the night, this is going to be wounds. Like you can see this forehead that have a big laceration and was healing there. The wounds, they are very important because all the management of the wounds will depend about the location, the size, and the timing of the wound. Which means the location is not the same to treat a wound here, as you can see here in the chest, compared like to treating a wound that is beside of a joint. That's scary, okay? And the size, I know this is big, but also we need to know about the size of that wound and the depth of that wound to know that if we have any kind of communication, a deeper tract, or the best way trying to address this kind of injuries, because each one is completely different and we don't have a recipe to treat the wounds like in general, okay? And also the timing. The timing is pretty important because we have a golden period for treat the wounds. This goes between the 4 to 12 hours. Ideally, needs to be seen in less than 8 hours so we can have fresh edges, vitalized, that in case that we need to approach them with some stitches or maybe staples, we can have the chance and a high successful rate. As you can see, this one has like this big gash. This is very superficial. This is a little bit deeper, but still is only involving like the skin of that chest. And we place some staples, stitches. It was a combination here, and the wound healed like very well. In the other case, like that you are looking here, this is a forehead that we have a fracture. Maybe you can see here, there's a small hole. Oh my goodness, that's the next one. Was a surprise, sorry. You can see here that we have a fracture. The fracture of this skull was stable after perform the radiographs. So then we decided only like to place staples on, and that it was, okay? And also another thing that is important for us is like to know if the horse, usually we check it in our files, but it's very important to know that if the horse has had a tetanus booster more than 6 months ago, before that we have the wound, then we need to give another tetanus booster to diminish the possibility of having a tetanus disease, okay? Because usually the tetanus disease is a neurological disease and it's fatal. Okay, this is another case. As you can see it here, this is a small wound. Maybe this is like 3 centimeters of diameter, but it's just above of one of the joint capsules from this carpus, okay? Because as you can see it here, we want to see the configuration of the wound. We want to scrub this, treat it aseptically, because whenever we start to examine our wound, this is a sterile teeth cannula that helped me like to probe the wound, to see how far can I go, and maybe sometimes even access to the joint and have synovial fluid on the output of the wound. That wasn't the case, but because the proximity of this teeth cannula to the joint capsule, I decided to tap the joint. We pressurize it to see that we don't have sterile fluid that I put with a syringe towards this needle going out from this side of the joint. It wasn't the case, so we just medicate the joint and then we start to deal with the healing of the wound by itself. If this were another potential scenario and we can have a communication here, for sure, gold standard, we would like to refer the horse to the hospital so we can treat this surgically. The gold standard always is lavage the joint to avoid a possible septic joint. We can make some far management as well. Sometimes, the rates of still having a septic joint beside of that we can put some antibiotics inside of the joint or maybe make a regional perfusion. They are still there and we can have them. So what to do? Again, I have been repeating this all night long, but call the veterinarian. Please forward pictures of the wound. It's very important for us, as I mentioned it, the configuration, the site, to know I think that all of my colleagues, we are the same, but in the meantime that we are arriving there, we are preparing a plan in our heads. So that can be much easier and quicker, to address this kind of emergency situations, okay? If you see that there's some manure or dirt that can, over the side of the wound, that can be removed gently with clean water, ideally sterile saline, and more ideally, if you have maybe 20 to 35 ml syringes that they are sterile, new, and these needles of number 18, you can draw some sterile saline and flush it maybe 20 or 30 centimeters away of the side of the wound. If this wound is beside of a joint, possibly you can hesitate about it and that will be completely fine and you want to wait until we arrive. But in this case, as you can see in the picture, this is the hook and this is above the hook. So the odds to have a communication with this joint right now, they are less compared if the wound will be here. So you can apply this sterile saline with some pressure, and that can help us to mechanically remove some of the bacteria that right now is attached over that wound. Now going back and forth with the first aid kit, when we have a profuse bleeding, we can apply a clean pressure bandage on, because we don't want the horse, if maybe because of the wound we touch an important blood vessel, as you can see here, the saphenous vein, and possibly that is good, and then we need to hold some pressure there and avoid the horse keep bleeding out, okay? Because that can be harmful for him. Please do not apply any ointments while you are waiting, because sometimes we think that this can be beneficial, but sometimes even the ointments apply over the wounds, and I know that we use different kind of ointments all the time, like flamacin, honey, Bioderm, a lot of the things that sometimes not all of them work in the same way that we want over the wound. Again, we don't have the perfect recipe to treat the wounds. Each wound have their own recipe, okay? And the last thing, if you see a foreign body, please do not remove it, because if you remove the foreign body, possibly this foreign body is holding a blood vessel, and then just take it out and we have a massive bleeding. So we don't want to go in that direction, okay? Referral option, yes. I think I put it here in this last point, but when we have a potential joint communication, I think the best decision is to refer our patient to the hospital if this is open in the budget of the horse. Because as I told you, sometimes this is the gold standard. We reduces a lot of the chances to develop a septic joint, most of all if this is treated promptly, possibly within the first 12 hours, so far 16 hours of the wound. And also, we have another reasons to refer patients. A non-healing wound, as you can see, this horse from here, from this previous image, is the same on these two pictures, okay? This is the day one. Here, we already clip the hair of the edges. We start to clean. He has an active bleeding at that time. And I know that maybe he had some muscular structures affected. But sometimes, because this can happen, we start our protocols, we start to treat the wound, we scrub it, there's no communication, we start the antibiotics, and we are expecting that this moves forward. But this is 3 days later. As you can see, the edges of the wound, they are white, they are devitalized. We have here like a possible layer of bacteria and necrotic tissue. So this horse, I debride this place surgically again, but doesn't matter what I did, it keeps going on the wrong direction. This is a case that needs to be referred because you don't want to have a non-healing wound for a long time. Now, some of the wounds, we can catalog them in non-healing wounds when we have proud flesh, because also that can be a secondary complication that we can manage in the barn. But the proud flesh, when we have proud flesh, this is because we are having a healing tissue, but this is like healing more quickly compared with the edges of the wound. We want to approach the edges of the wound, and the thing that is like filling that wound, that tissue is going out from the wound. Okay, this is different because in that case, we can only cut that proud flesh, trying to apply pressure bandage, control the area, and usually with time and patience and treatment, this heal up. In this case, as you can see it here, this was a non-healing wound. We have an infection, a persistent infection. This horse went to the hospital and this was inoculated by a very multi-resistant bacteria. And that was the beginning for a long process to keep healing that wound, okay? And also, as we discussed it, joint communication. This was a call that I had for a second opinion. This horse was seen before, like maybe, I don't know how long before, like maybe 2 weeks before. But we have this communication. The horse was non-weight bearing, and we placed our teeth cannula, and this was going inside of the pastern joint, and we have like these septic changes in our imaging. This can be the consequence of don't act promptly, and unfortunately, we need to put down this horse, okay? So this is only a reminder that whenever you see a wound that can be close to a joint, we need to see it, we need to assess the horse, and we need to decide what is the best options for treating these cases, because this case is tricky. If you don't have this image on your left, only with this wound, you possibly can think, in my mind, I can think that possibly this can be communicating with the lateral pouch of the coffin joint, but also is above the pastern, and this was communicating with the pastern, okay? So things can happen, horses are horses, and that is very important. And well, that was my last slide. I hope that you have enjoyed this presentation, and if you have any kind of questions, I will be happy to answer them.
Thank you so much. And just a reminder to everyone watching that to ask questions to Dr. Sid, if you could please just put them in the chat box below, and then we'd be happy to answer them.
Okay, so I don't know if do we have questions. I don't see any kind of questions in the chat. I don't know if this is very clear, but you can let me ask whatever you have any kind of doubts, okay?
We we've gotten a couple of comments, just people thanking you for a really great and informative presentation so far.
Thank you so much. My pleasure.
We'll leave this open for a few more minutes here, just if there's any more questions. Yeah, thank you.
About tendon injuries, Okay. I think that we think about, because here we have a question from Elizabeth and Julia, and they are asking about like, can you tell us about tendon injuries? Well, the tendon injuries, they are some of these kind of injuries that not all the tendons in all their anatomic structure, they are involving a tendon sheet, but also a tendon sheet, this is a structure that acts like a joint capsule, okay? So when we have a possible wound that can be affecting the joint, the synovial tendon sheet, like in just above the fedlock, the back aspect of the fedlock, or just below of it, then we can think about a possible septic tendon sheet, and that also can be a referral option. But overall, like some of the wounds that also can involve the tendons, they are not involving only they cannot like involve only the tendon sheet. They can be in different parts of the tendons. And also we need to decide what is the best approach for this. Sometimes some horses, they can just cut the tendon right away, and that can make us a big problem, because sometimes these horses, they are like very lame, and then we need to address the situation in a different options. Sorry, in a different way. I hope that I answered your question properly. If you have any other doubt, you can write down in the chat. Okay. Thanks for everyone that you are like sending your regards. It's fantastic to speak for you. And for Reese, he's asking, should you clean a wound with water multiple times over multiple days? I will say, like, after you have been assessed by your vet, then you can clean the wound with clean water, but this depends with the protocols that your vet suggests to you. Okay, because for me, if I know that maybe we have a superficial wound, maybe above the fedlock, it never penetrate the joint capsule, maybe yes, I know that we can apply a light bandage on in the meantime that this is healing, and we can scrub the area, maybe with an antiseptic, maybe iopovidone soap, or maybe chlorhexidine soap, and then rinse it with clean water, and that is enough for me. Okay, but only the water by itself, I think that in the case that we mentioned before, like, okay, if you think that maybe we can have joint communication and you want to don't do anything, I think that's fair. But if we see that, well, maybe this is something just on the shoulder of the horse, okay, then we can clean like only gently with clean water, rinse it, and in the meantime, we are right there and we give you our best advice, okay? So when should hydrogen peroxide be used on a wound? That's a really good question, because I have seen that there's a lot of people that they love the peroxide, because usually we think that this is not harmful, and most of all, this is pretty safe and also don't burn. Like, if you put alcohol, the horse will have a reaction, as such, like you can have like this burning sensation, and you will say like, no alcohol, right? And honestly, right now, I think that it's been a long time that I don't put alcohol in a wound. But for the hydrogen peroxide, I think that you can use it at the first time, again, if we don't have joint communication, because anything that can get into the joint, even the peroxide, can irritate the joint capsule, okay? Maybe we don't have a septic joint, but then we can have a reaction, a chemical reaction inside of that joint, okay? Talking about wounds that they are beside of joints. But in a wound that is not over a joint, it's in another place, it's superficial, you can use it like first aid the first time, and that's it. No more peroxide, okay? Because the peroxide, long term, is going to delay the rate of healing of that wound, okay? If the peroxide can make your hair like be blonde, then also can create like a damage and a delay of the healing of the wound. Okay. And to Mary, I've heard the peroxide can damage skin tissue. Is this true? Yes. Long term, yes, it can do it. The only like a first application is fine for me. The Banamine should, for Blake's Cooper, the Banamine shouldn't be injected intramuscular because unfortunately we have some bacteria that they are called Clostridiums. The most common, Clostridium tetani, that produces the tetanus, Clostridium botulinum, that produces the botulins. We have another kind of Clostridiums that they like to attack the muscles. This is more often with the cattle, okay? But in the case of the horses, it has been reported that after we applied injection, an intramuscular injection, only for Banamine, we are not talking about bute because the bute never goes intramuscular. But specifically, Banamine, after we apply it, maybe 2-3 days later, then we have an infection secondary to the site of the injection because this has been inoculated with this Clostridium, with these anaerobic bacteria, and they like to produce a lot of gas and eat basically the muscle. If you go to the web and try to look for it's myonecrosis secondary to site injections in horses, you will find a lot of pictures that maybe you can see like a very wide damage on the neck from the horse, and it was only one needle, only one small shot. So that's why you shouldn't be giving these kind of shots intramuscular, okay? Always, if you have somebody that is trained, properly trained to give it IV the Banamine, that would be great. If done, you can give it orally. And a last thing that I forgot to touch, in the case of the chokes, you can give some Banamine IV, but of course, if the horse is choking, he won't be able to swallow the Banamine, and maybe the dose won't be effective. And when we arrive there, usually, if you haven't given any kind of Banamine injectable IV, then we are going to give some Banamine because also we want to this esophagus gets de-inflamed, and that can be like more easy for us passing that tube towards to the stomach. Okay. Approximately from Kelly, approximately how long does it take for orally administered Banamine to start to take effect? Around half an hour, that should be enough to start to take effect. And from Grace, when would you use betadine versus chlorhexidine? That's a good question. I don't think that there's a thumb law. I think that something that you can find more often, even in the human pharmacy, is the betadine. So I would rather use betadine in these cases. I will only use chlorhexidine. Usually when I arrive to the barns, this is like the antiseptic that I have in my scrubbies, and I use it like just for the first intention because it's easier for me, but also because I know that I'm going to rinse it pretty well. Sometimes we use diluted chlorhexidine. Sometimes we know that the chlorhexidine also can be more aggressive with the skin compared with the betadine. So that's why sometimes we prefer going on that direction. But always, that's why we make a huge protocol, arrive, see the wound, clip the edges to don't have hair in the edges of that wound and avoid contamination, scrub it with the chlorhexidine, then we rinse it with pressure with sterile saline, and then we start to assess the wound. It's a whole protocol, but all those steps have a reason behind, okay? I can do it again like with betadine, but sometimes the betadine, we prefer like for our joint scrubbing when we are going to do some joint injections, and that's a completely different case because that's an elective procedure, okay? And I think that right now I have answered all the questions. I don't know if you have some others, but thanks to all of you, it was fantastic to have this webinar with you guys and to can share like all this information, because I think that we always need to have at least a little bit of background to perform our duties. Most of all, when you are horses owners or trainers or barn staff and you work at the barn.
Just while we give a couple more minutes here for anyone to put in their questions, I'm just going to type into the chat box just the email for anyone keeping track of their webinar time. So to either be entered in to win our first aid kit or any OABT members for their hours. I'll write in the email address you can send your information to so we can make sure you get entered or applied for your hours.
Okay, in the meantime, I'm going to say thanks to everyone that are sending regards, and to Shell from Richmond Hill, Ontario. Thank you so much for assisting tonight to this webinar. Christy, Lost Hall, thank you as well. Blake Cooper, Elizabeth and Julia, Lindsay, Melinda, Reese, Sue, all the people, Grace Breton, Mary, Blaze Cooper, Kelly as well, Sue, Dawn, and all of you, Mary, thank you so much. Thank you so much for being tonight. And I can answer that question as well. I think that yes, you will have access to this webinar. I think that this will be launched in our website, so you can see it at any time that you want it, okay? Very good.
Perfect. Well, thank you so much, Dr. Sid, for hosting this webinar tonight. It was very informative. Yeah, thank you so much to everyone for joining as well. We've got one more webinar left in the webinar series that's coming up at the end of April. So stay tuned for information about that, or sign up if you haven't already. And yes, thanks so much, everybody, and we hope you have a great night.
Thank you so much. Have a great night. Take care.